Okay, welcome everybody to this evening's Q&A on the kidney. What I'd like to do is to review for you, give you a general overview of how the kidney functions, the importance of the kidney to the biology of the human body, and then discuss the diseases that affect the kidney and how doctors diagnose these diseases. And then also go over some of the diseases that still require research and what is being done along those lines. So as shown on this slide, this is just a general breakdown of the diseases of the kidney, shown in a pie diagram. And what is very clear is that diabetes is the greatest cause of kidney disease. About 44% of all patients with kidney disease, it's due to diabetes. And I'll show in a later slide how diabetes affects the kidneys. So if you go into any dialysis unit or any kidney clinic, about half the patients are going to be there because they have diabetes. And we'll talk about how this disorder that lay people think only affects sugar, how it affects the kidney and why it causes kidney disease. Now, another big group says high blood pressure, and you'll find this on all registries. And this implies that high blood pressure actually causes kidney disease. But in fact, it's most likely that the chicken and the egg is reversed, that it's other kidney diseases that lead to high blood pressure. And we'll talk about that a little bit. There are smaller groups. One that's 7% is called glomerular disease. I'll talk about what the glomerulus is and what those diseases are. There's a smaller group that's made up of what's called polycystic kidney disease. This is the most common genetic cause of kidney disease, and I'll show some examples of that. And then there are many other causes of kidney disease that we'll discuss at length later. But the take-home message from this slide, if you forget everything, is that diabetes is the elephant in the room. And if we could solve diabetic kidney disease, we would get rid of about half of the kidney disease on the planet. Now, if you look at the number of deaths per year in the United States from different diseases, what you see is something amazing that the general public is not aware of. Let's just start on the right. The number, and this you have to multiply by 1,000. So, for instance, the number of people dying each year in the United States from prostate cancer is roughly 34,000 people. If you think about what the U.S. population is, that's a pretty small number. And the same with breast cancer, even though breast cancer seems so prevalent. Roughly 43,000 people die each year. It's a pretty small number compared to the total U.S. population. Colorectal cancer, 53,000. But look at kidney disease. 100,000 people die every year of end-stage kidney disease. Very few people know this. And if you ask the general public, no one would even ponder that the number of people dying from kidney disease is, more than 2.5 times breast cancer. The only cancer whose deaths exceed kidney disease is lung cancer, and not by a lot. It's 135,000 a year. Now, what about the data on the prevalence and the cost of kidney disease? Worldwide, more than 850 million people have some form of kidney damage. And if you think that the world's population is about 7.7 billion people, that's about 1 out of every 9 or so people have kidney disease worldwide. Now, these aren't people on dialysis. They have some form of kidney dysfunction. It's not severe enough necessarily to be on dialysis, but they don't have normal kidney function is the implication. Now, what's not known generally is that African Americans and Hispanics, of the total number of patients in the US that have kidney disease, have a much higher proportion of the total than based on their population. In the US, there's about 40 million people that have some form of kidney disease, and there's about 650,000 people on dialysis. Now, in the 1970s, a bunch of nephrologists went to Congress and said that because we have this new form of treatment called hemodialysis, it would be unethical for the US government not to pay for this disease. Now, Medicare was being created at the time, and Medicare was not a program to fund a disease. It was a program to fund population once they reached a certain age. But because these nephrologists went to Congress and convinced Congress, they decided also that Congress would pay for kidney disease. Now, it's the only disease that Congress pays for. And last year, it cost the US government about $114 billion for all its kidney care, which is about 1/5, 1/6 of the entire Medicare budget. So it's a huge fraction of Medicare spending goes to fund kidney disease. Now, if you look at the dynamics, simplistically, there's about, as I mentioned, there's about 650,000 people who are on dialysis. About 100,000 new patients a year go on dialysis, and about 100,000 die every year. So the number stays about 650. Now, our goal as nephrologists is to do two things. One, to decrease the number coming in. We want to get that 100,000 to be 80,000 or 70,000. That's what a lot of the new medications are. And again, remember, about 50,000 of those patients are diabetic, around half of those. And we want to decrease the number of people obviously dying each year who have end-stage renal disease. Okay, now if you look at the normal kidneys, they're about 1/3 of a pound each. They're on the back of the abdomen. It's hard to tell here. They're sort of in the upper part of the abdomen. They weigh very little, but they're more towards the back. Now, coming out of the kidneys are these tubes called the ureter. That's the urine comes out of the kidney, and then it goes into your bladder. Now, the kidneys are constantly making urine, 24 hours a day, 7 days a week. The kidneys don't know what sleep is. The kidneys don't know what a vacation is. The kidneys don't know what I'm tired means. They're constantly working your entire life, constantly making urine. And the bladder fills up after you void continuously. Now, we don't get the sensation that we have to urinate until the bladder fills up to about what we call 300 milliliters or so. It's a couple of glasses of urine, if you want to think of it like that. Until then, you don't feel like you have to void. So it takes a certain volume in the bladder until you have to void, and people think, oh, well, my kidneys must be making urine only intermittently. But that's not what's happening. The kidneys are constantly making urine, and after you void, the bladder starts filling up again, and it reaches a certain volume until you have to go again. Now, people who don't have kidney function don't make urine, and we'll talk about that. So what about the normal kidney? Well, in each kidney, we have these functioning units that we call nephrons. And there's about 1 million in each kidney. And you can think of the nephron as a filter. We call the filter a glomerulus. That's the name of the filter. And then after the filter, we have, you can think of it like a pipe, but it's very, very small. You only see it under a microscope. That does the rest of the kidney function. And the rest of it is to take different substances like salt and potassium and different chemicals and either put them into the pipe or take them out of the pipe, such that the final urine has the right chemistry. But the initial part is the filtering of blood. So blood comes into that little filter, and what comes through the filter is just a solution without the components of blood. So no blood cells, no the white cells, all the cells in blood don't get through, nor do the proteins that are in blood, like you might have heard of albumin, that doesn't get through either, if the filter is functioning normally. Now, a number of the diseases, and as I'll show, including diabetes, affect the filter and make it not work properly. So what are the functions of the kidney? Well, one of the functions of the kidney is it has to get rid of all the salt that you eat. So here's just a cartoon. It says at the bottom there, the patrons at table 5 want to know how you manage to get such a wonderful taste in your salt-free soup. So, you know, this person's just pouring a ton of salt in the soup, but it's going to be up to the kidneys of the people at the restaurant to get rid of that salt. So every day, the kidney recognizes how much salt you take in with your diet, and it makes sure that you get rid of the salt. Now, the reason that's important is because the salt in your body determines your blood pressure. And the reason for that is when you take in more salt, your kidney retains more water. And when you retain more water, there's more water in all your blood vessels, and so the pressure goes up. And that's not a good thing. So the kidney regulates your blood pressure by getting rid of salt. And there are some people who can't get rid of salt properly, and their blood pressure goes up. Now, the kidney also gets rid of water. Here's a cartoon in the doctor's office. Your tests reveal that you're retaining fluids. Well, that will happen if the kidney is not functioning normally. Patients start to retain fluids. They get swelling in their legs. They can get swelling, obviously, throughout their body, depending how much fluid they retain. Kidney also gets rid of something called potassium. This cartoon says, and this dish is totally potassium free. There's nothing in the dish. And that implies that, you know, potassium is just everywhere. It's in all the foods we eat. And to get to 0 potassium, you really have to not eat anything. And I'll show some examples of where potassium is. And potassium is very important because it controls the electricity in your heart. And if the potassium in your blood goes up or goes down above normality, you get all sorts of electrical problems in the heart. So it's very important that the kidney keeps the potassium in your blood very constant. Now, potassium is found in fruits, shown here. So if you eat 10 bananas tonight, you're going to have a lot of potassium coming in. There's also potassium in meat and fish. And the kidney, again, recognizes how much potassium came in with your diet and makes sure that in a 24-hour period, it gets rid of the appropriate amount of potassium in order to keep the electricity in your heart, shown on the upper left there, appropriate, so that your heart beats normally. The kidney also gets rid of something called nitrogen. And there's a lot of nitrogen in meat. And so the kidney recognizes, again, how much nitrogen is coming in your diet and makes sure that in a 24-hour period, it gets rid of exactly the amount of nitrogen that came in with your diet so that your body nitrogen levels stays normal. Now, the kidney also controls blood pressure, as I mentioned, because of the dependence of blood pressure on the amount of salt and water in your body. So first, you retain the salt. That's going to make you retain the water, and it's the retention of the water which is the bad part, because that water has nowhere to go. It fills up your blood vessels, and now the pressure in the blood vessels is higher. And it turns out that 45% of Americans age 18 and older have high blood pressure, and they don't recognize it because, you know, unless it's sky high, you don't feel a thing. So most people don't know. Most people don't like going to doctors, and so they never find out. And the American College of Cardiology in 2017, I think it was, lowered the level to 130 over 90 or 130 over 80. It used to be 140 over 90. So this 45% is based on this new lower number. But everybody over 18 should have a blood pressure cuff in their home, and everybody should be measuring their blood pressure when you're at home, because the blood pressure in the doctor's office is always higher than normal because people are nervous. And we never treat patients based on the pressure we get in the office. We go by what they get at home. Now, the problem with blood pressure is that it's like the weather. If you measure it, it's fluctuating all the time. It's different in the morning, in the afternoon, and at night in a normal person. And people with high blood pressure, it also fluctuates. So when we give someone a blood pressure cuff, we tell them, initially measure it at least 3 times a day, morning, afternoon, at night. That way we can get a feeling of when the pressure is abnormal, because some people have high pressure in the morning, others have high pressure at night. If they only measure it in the morning, we might miss in some people the high pressure at night. So we like to cover the whole day by getting at least 3 measurements. And plus, differs based on whether you're lying, sitting, or standing. So we tell everybody, if you're going to do it from day to day, do it the same way. If you like doing it when you're lying, get the pressures lying all the time. If you like it when you're sitting, do it sitting, but don't mix, because then it's going to make the pressures different just from the change in your posture, and it makes it hard to figure out what to do. So if, let's say, someone has high pressure at night, not in the morning, that will alter how we offer the patient blood pressure pills. We might decide to give the pills in the morning or in the afternoon to cover the high pressure at night. We wouldn't give the pill at night because the pressure in the morning is normal. Remember, the pill doesn't work right away, so we have to build in a delay after we give the pill, whereas someone who has high pressure in the morning, we'll tell them take that pill at night, that kind of thing. So anyone on the call should get a blood pressure cuff. The kidney also controls what we call your blood count. And what we mean by that is how many red blood cells, how many red cells are in your blood. And if the red cells are too low, you get what's called anemia. You might have heard that term. The kidney does this by creating a hormone called erythropoietin. The erythropoietin then goes to your bones and tells the bone how much blood cells to make, because the blood cells are made inside your bone marrow. That's where the factory is to make the red blood cells. They live about 180 days or so, and then they're destroyed. So the bone marrow is constantly making new red blood cells, but it knows how much to make because it gets this signal from this hormone called erythropoietin that's actually made by the kidney. So if you have kidney disease, the amount of hormone erythropoietin that the kidney makes may decrease, and that can lead to anemia. So our patients who are on dialysis don't make erythropoietin if their kidneys are really damaged, and we have to give them the erythropoietin artificially. That's how Amgen, many years ago, the pharmaceutical company Amgen made it to billions of dollars. They synthetically created erythropoietin for the first time, and now for the first time in human history, we could treat the anemia of end-stage renal disease very nicely, and that still goes on today. The kidney also is responsible for the health of your bones, and it's also responsible for the amount of calcium and phosphorus in your body, because it makes a hormone called 1,25 vitamin D. So when you go to the pharmacy and you say, I want vitamin D tablets, that's not the vitamin D that is active. The kidney takes that vitamin D and converts it into another form called 1,25 vitamin D. And that's the form that actually works on your bones to keep them healthy. So when the kidney's not working well, it doesn't make enough 1,25 vitamin D, and we have to give the patient vitamin D. Sometimes we give the 1,25 vitamin D to make sure that their bones are healthy and that the amount of calcium and phosphorus they have in the skeleton and in their blood is what it should be. So what are some diseases of the kidney? Well, diabetes, I mentioned. There can also be kidney cancer. Just being very obese for some reason causes kidney damage. It's not entirely understood why that occurs, but that there seems to be an association. There are people with kidney stones. There are other what we call inflammatory diseases of the kidney. You might have heard of this disease called lupus, where the kidney gets very inflamed and damaged. We have other diseases we call the GNs. There's many of those. I won't get into that now. There are genetic diseases of the kidney. I had mentioned polycystic kidney disease. I'll show an example of that. Viruses can attack the kidney, like AIDS or COVID-19 has become prevalent in the last couple of years. It was not known, but people with COVID-19 get kidney disease because of virus in the kidney. It's not just a lung problem. There are bacterial diseases of the kidney. There are many drugs that can harm the kidney. One you should know about are what we call the non-steroidal anti-inflammatory drugs like Motrin, Aleve, or ibuprofen. I'm sure you've heard of those drugs. People take them all the time for pain. Well, those can damage the kidney, and we've had patients who have totally destroyed their kidneys because, let's say, they had back pain and they were taking 4 or 5 Motrin every day for like months and months. Well, that can severely damage the kidney in those patients. can get so damaged that they need dialysis or a transplant. So it's safer to take Tylenol if you have pain. Now, you can take these other drugs if you don't have kidney disease, but don't take a lot of them. But certainly once you develop kidney disease, you should stay away from those drugs for the rest of your life. There are other diseases that we call obstructive kidney diseases or obstruction. When the prostate gets too big, it can block the urine flow from the bladder, and these patients have a hard time urinating, and the pressure, the back pressure, can back up all the way up into the kidneys and damage them. So if you have kidney disease, no matter what the cause, what can that lead to? Well, you can sort of guess based on what I discussed as far as the function. It can lead to fluid overload, which could lead to swelling of your feet, or very severe swelling of the upper parts of the body. When you have severe kidney disease, it affects your appetite and it can actually make you nauseous. It can raise your blood pressure. There are what we call electrolyte disorders of the blood. These are disorders that affect some of the chemicals in the blood that the kidney regulates. These are chemistry terms. Na is sodium, K is potassium, Ca is calcium, Mg is magnesium, P is phosphorus, HCO3 stands for bicarbonate. The kidney keeps all these constantly at a certain level in your blood, and when the kidney is damaged, the concentration of these things can be altered significantly, which can then lead to other problems. You can get anemia, as I mentioned. Patients with kidney disease are often depressed, and it's sometimes hard to distinguish symptoms of depression from the changes in the brain that occur just from kidney disease itself. You need to take professional tests to distinguish those. People are often misdiagnosed also as being depressed when they're not. It can cause sleep disturbances. A lot of patients with kidney problems have problems sleeping at night. They tend to sleep on and off or sleep during the day. They can have sleep-night reversal. And it can affect the taste in your mouth. The food, people with severe kidney disease, they just say the food doesn't taste normal. Now, there are new drugs for that for some patients, not for all, but we just tend to recommend, spicing up the food and making it more interesting, where you might enjoy it more. But it's a problem for patients. Now, it's important to realize that kidney disease is the tip of the iceberg. We have patients in the United States who can have up to 50% loss of their kidney function, and they're not diagnosed. Now, what we mean by that is that when we say kidney functional loss, it's a term that the doctors will use. We're not talking about all the different functions I mentioned. We're talking about one function, and that's the filtering function, due to the part of the kidney tubule that we call the glomerulus. That's the little filters there. Remember, you have 1 million of those in each kidney. If you lose up to half of those, you will have what we call kidney functional impairment, but you won't have anything that led to. And so you don't go to the doctor, and no one makes the diagnosis. And that's a problem, because one of the major problems of kidney disease is that people don't know about it. It's undiagnosed. And we'll talk about how to make the diagnosis. And when you'll see how easy it is. If the kidney function goes down to 15% of normal, usually at that time you need to start dialysis. So we have a big reservoir of function. You can be 50% of normal and you don't need dialysis. You can be 30%. When you get down to about 15% of the total function left, and by function, I mean the filtering function, then you need to do something. And one of the options is hemodialysis. And for this, patients come in 3 times a week, either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. They stay for about 3 hours, and they undergo a procedure we call hemodialysis. And after that, they just go home. Now, some patients sleep, some patients read, others watch TV in the dialysis unit. Dialysis unit can have 15 to 20 to 25 patients being done at any one time. And there's different shifts. So you can imagine that a given patient's only done for 3 hours. Well, the dialysis unit might open up at 4 or 5 in the morning and go to 8 or 9 at night. With the different shifts of patients that come in, we offer the patients different times depending on their needs. whether they're working or not, this kind of thing. But hemodialysis can affect your life. This is cartoon says, I do sympathize with you, sir, but I'm afraid it cannot be viewed as carry-on luggage. So it really restricts your ability to travel, because every time you want to go anywhere, you have to work out with that area a place where you can be dialyzed. And it's just something, you know, you have to start dealing with. And in most places, it's not an issue. Dialysis units keep chairs open for travelers so that they're not filled all the time. Another form of dialysis is what we call peritoneal dialysis, and this isn't done with needles in the arm like hemodialysis is. The patients have a tube that goes into their abdomen, and then they hook themselves up to a machine, and usually it's done while you're sleeping. And the machine takes solutions and puts them into your abdomen, and then takes the solution out, and it does this usually 5 times a night. You're sleeping, you don't know what's happening. And then in the morning, you just uncap yourself and you go about your business. And at night, before you go to sleep, you hook yourself up. This is by far safer, and it's something that not only nephrologists, but the US government is pushing. And also it's done at home. So it gives people more independence. They don't have to go to a dialysis clinic 3 times a week. So for people that are able to do it, you have to be careful when you hook yourself up. You're wearing gloves, not shown in this picture here, where her hands are not gloved, and you're wearing a mask. You have to do it sterilely because you don't want to infect the catheter that's going into your abdomen. But if you do it carefully, you won't get any infections, and it's a very gentle and nice way of being dialyzed. The solutions are delivered to your home, so you have to have the space for that, a separate room where you keep those solutions, and then they're taken away. They use the spent ones. If you get a kidney transplant, that's the best option, because now you have an organ that's functioning like the native kidneys. People often ask, well, what happens to the diseased kidneys? They're left in place. The reason they're left in place is there's always some sort of function they have, like they might be making some of the 125 vitamin D, or they might be making the erythropoietin, or they may be still filtering to some extent. So why, even if they're filtering 15%, why would you want to remove that remaining function? Any little bit helps. And so patients have 3 kidneys. Now, where are the areas that people are still working on to try to improve kidney care? Well, if you think of dialysis, it's been around for a long time and hasn't changed. I mean, hemodialysis was invented in Holland during World War II in 1942 by this physician called Kolff. When the Nazis were occupying Holland, he was in a small, tiny hospital inventing dialysis. But basically, the therapy has not changed since then. The second therapy, peritoneal dialysis, came to the fore in the late 70s. But again, it's same sort of therapy. Shows a patient in a chair here, but as I said, most patients are doing it at night while they're sleeping. So one of the areas that people are trying to work on is to develop an artificial kidney. And we're doing that at UCLA. These are just some of my co-workers. Roland Ludlow is CEO of a company called US Kidney Research Corporation. They are spearheading the funding of this. And I'm also working with scientists at Arkansas University, headed by Jamie Hestigan, who's a chemical engineer. And these are some of the students and postdocs that are also working on the project, something we've been doing for about 6 years now. And now I'll show a little video. It'll give you a little overview of the artificial kidney project.
The function of a kidney while still fitting within a backpack to enhance the patient's quality of life. While the device consists of many different functional modules, the combination of sensors and smart software allow an easy interface for doctors to view patient data and patients to manage small changes to accommodate their daily activities. The purifying process begins with blood flowing from the patient through a catheter, as shown in red on the top right. It then flows to a peristaltic pump and enters the ultrafiltration module, which is shown as a cylinder on the far left. This module retains proteins, white blood cells and red blood cells to be returned to the patient's bloodstream through a separate catheter, as shown by the red stream returning out of the top left. Our system uses a unique nanocellulose membrane, which allows for minimal fouling as well as a high flow rate. The module allows smaller substances dissolved in blood, such as glucose, urea, and ions, to pass through as shown as the blue stream leaving the bottom of the ultrafiltration unit. From there, the stream flows through a sensor bank to analyze the patient's initial ion and urea levels to determine the removal amount using the SMART software. Next, the stream is pumped into an electrodeionization module, which is shown as the blue flow into the top left rectangular module. The electrodeionization module uses an electrical potential to selectively transport various ions, mainly potassium. The ion-depleted stream is then sent to a level sensor to monitor the flow rate and pumped into the bottom port of the nanofiltration module, which is shown as the second cylinder on the right. The nanofiltration module is used to separate glucose, which needs to be returned to the body, from urea, which needs to be excreted in the urine. The stream with the concentrated glucose is returned to the body through the catheter. The stream with the concentrated urea is shown as the blue flow exiting from the top. From there, it is sent to the activated wafer electrodeionization, or a WEDI module, which is shown as the rectangular unit on the top right. The WEDI module contains multiple wafers that are selective to different ions. This allows for ions to be transported in different amounts depending on changes in the patient's blood chemistry due to alterations in dietary intake. The SMART software calculates the amounts of different ions that need to be removed based on input from the sensor bank. The stream with the ions removed is then returned to the patient's bloodstream. A second stream, which contains the concentrated urea and ions for removal, is recycled back to the first electrodeionization module, where it picks up the potassium that needs to be removed. This stream is then pumped through a level sensor to determine the flow rate, and then to the reverse osmosis module, which is shown as the cylinder on the far right. The reverse osmosis module is used to prevent excess water loss in the patient and to concentrate the synthetic urine stream, which contains the urea and ions for removal. The flow comes into the bottom of the unit, and clean water is sent out the top and back to the patient, while the synthetic urine stream is sent out of the bottom for disposal.
Okay, well, that was, very technical and likely complex to understand. But what I wanted to convey here is the complexity of what we have to do as humans to replicate the function of the kidney. The kidney is a miracle creation, and I've only shown you some of what it does, but it's very hard to replicate synthetically. And so what this project attempts to do is to replicate only the essential functions to keep people alive. Humans will never replicate everything that the kidney can do, but we don't need to medically. Anyway, this is an ongoing project that hopefully you'll hear more about. It was very nice for us that in 2020, GE named our project one of the 5 coolest things on the earth that particular week. So that was a big honor for us. So let's get to some of the diseases where research is ongoing and where the big challenge is in kidney disease. So it says in the cartoon, God sent Adam and Eve out of the garden because of the apple. Apples have carbs, and carbs are evil. What diabetes does to the kidney is the following. First, it destroys blood vessels. So when you have diabetes, as you can see on the top right, on the left is a normal blood vessel. On the right, it has all this yellow stuff and plaque and fatty deposits, and the blood vessel gets narrow. And when that happens, the organ doesn't get the right amount of blood flow, and that can lead to organ functional impairment. And it isn't just the kidney, it's all the blood vessels in the body. So if it's in the heart, you can get diabetes causes heart attacks. If it's in the brain, you can get a stroke. And in the kidney, it causes kidney damage or kidney failure. Now, the second thing that occurs in the kidney is that it affects the filter. So on the left, bottom left, is a normal filter cut with a blade. It's just we call a section of a filter. You can see all the little capillaries are nice and open. But look at the one on the bottom right. That's a diabetic glomerulus, and you can see it's filled with this material. Well, it's not going to filter very well. And that takes usually about 18 years in a diabetic, from when the diabetes started till when they're really going to need what we call renal replacement therapy, either with hemodialysis or peritoneal dialysis or a kidney transplant. So diabetes damages the blood vessels, as you see up there on the upper panel, and it damages the filters. And this process is what's going on in half of the people with kidney disease in the world. So it's a major challenge for drug companies and nephrologists. And if you had to look at all kidney diseases, as you might expect, most of the money is being put into solving diabetes. We haven't done that yet. Another one is kidney cancer. Kidney cancer doesn't damage the function of the kidney, but it's cancer like any other cancer. And so you can see here on the left a cartoon of a cancer growing within the kidney. Now, it's obviously going to destroy that local area of kidney, but the rest of the kidney is fine. So these people tend not to have kidney functional impairment, but they have other issues related to the cancer. And on the right, you can see a mass in a patient with the arrow pointing to the cancer within the kidney. There is something called a kidney stone that you might have heard of, and you can get little stones forming anywhere within the kidney. And there's many different types of stones. Most of them have calcium, but not all of them. Some of them are made of we call urate, which you get in goat. Uric acid goes up in your blood in goat, but uric acid can also come out of the kidney excessively and make a stone. Having a kidney stone come out, people who have had it, and this is what we teach in medical school to the students, is the worst pain you can have. It's worse than giving birth to a baby. It's the most excruciating pain a human being can feel. And it goes from your back all the way around the front into the groin. It's excruciatingly painful, and we have to give morphine to stop that pain. Now, not all stones cause pain. Usually it's a stone that is not coming out, and it's what we call obstructing the efflow from the kidney. So where the ureter, the tube coming out of the kidney that you see in that picture, if a stone gets stuck in there, the kidney is trying to get that urine out, and the pressure builds up very high, and that's what creates the pain. If the stone is small enough, it'll just come out in your urine, and sometimes people can actually see it. We tell people with kidney stones that have a lot of stones to, especially if they have the pain, to take a piece of gauze or something and pee over that and then catch the stone, so that they can take the stone into the doctor for it to be analyzed. Because if we know the analysis of the chemistry of the stone, we can come up with more rational treatment, because the different stones are treated differently to prevent the future ones. I mean, the treatment for preventing future ones differs depending on the chemistry of the stone. And millions of Americans have kidney stones. It's a very common thing. There's another disease that's very prevalent worldwide. It's one of the glomerular diseases that we call IgA nephropathy. These patients often present with blood in the urine, shown on the left there. Now, when we ask the students what's the most common cause of red urine, many will say blood, but it's not. It's actually people who eat beets. If you have beets and then you pee a few hours later, oftentimes the urine is red. People get very nervous and anxious. They think they're peeing blood. And we ask them all the time in the clinic, did you have beets last night? And they go, oh yeah, I did. So we tell them, don't worry, it'll go away. But if it stays red, you have to think that there's blood in the urine. And this one disease, IgA nephropathy, presents that way, as do many kidney diseases. They can present with blood in the urine. But if you look at the filter shown on the right there, it's filled with these abnormal cells. We shouldn't see those cells there. And then a stain at the bottom, looking for what we call IgA, shows this green fluorescence that we see typically in this disease. And it's very common in Asia, among Asians. Again, we don't know the cause of it. We have some ideas, and there's no good treatment for it right now. But it can lead to damage of the filters like diabetes can, and ultimately people can end up on dialysis. Another disease that I talked about, the genetic disease, is called polycystic kidney disease. It's called polycystic because the kidney, instead of having a nice smooth outline looking like a kidney bean, has all these huge blebs of fluids coming out of it that we call cysts. And these tend to occur at a certain age. Even though it's genetic, the kidneys look normal. Even though you've had the abnormal gene from birth, the kidneys tend to look normal until you get into your 40s and 50s. And then on MRI or CAT scan, we see the kidneys growing, and more and more cysts forming. And these cysts can lead to a lot of things. First, it can damage the kidney tissue, so they can end up ultimately on dialysis if they lose enough function. Or these cysts can actually bleed. So you can get blood in the urine, you can get pain when each one bleeds. They can lead to lots of problems, polycystic kidney disease. There are some newer drugs out there, but still it's a big problem. And about 10% of all dialysis patients have polycystic kidney disease. You can see a comparison of the size of an abnormal kidney with cysts there compared to a football. This is a totally different disease that affects the kidney. You may have heard about lupus. It tends to affect women, young women. The inflammation isn't only in the kidney. It can occur in the joints, so it can lead to arthritis. It can occur in the skin, can occur in the face, and usually the cheeks. They get what's called a butterfly rash. This is inflammation in the skin of the cheeks. You can lose your hair. You can be sensitive to sunlight. There's many manifestations of lupus. It can affect your brain. It's called lupus cerebritis. It can inflame multiple organs. But in the kidney, you can see the upper panel there. Again, the kidney, the filter is being affected. It's just filled with all these cells that you shouldn't see there. And the filter can get severely damaged. And again, ultimately lead to such loss of function that they need to be dialyzed. A normal filter is shown on the bottom there again, where the little blood vessels that we call capillaries are nice and open, and it's filtering very nicely. The one on top is not going to be filtering anymore. Again, I mentioned high blood pressure. It's a chicken and egg. You know, does the kidney damage lead to high blood pressure, or does high blood pressure damage the kidney? This is a discussion which goes on all the time among nephrologists. The truth is that is heavily weighted to the kidney disease causing the high blood pressure, because again, the kidney is responsible for regulating your pressure, and when the kidney gets damaged for whatever the reason is, it doesn't get rid of the salt and water normally, and they build up in blood and your pressure goes up. There are maybe rare instances of the high blood pressure for other reasons damaging the kidney, but the former is more common. Even though most nephrologists shooting from the hip will say, oh yeah, the high blood pressure damaged the kidney, but that's not likely the case. It's the former, where the kidney disease is causing the high blood pressure, is much more likely. Now, how do we test for kidney disease? Remember, we have 1 million filters in each kidney. Shown on the left are just 4 or 5 of them. That you can think of them like grapes, actually, but imagine 1 million of them, how many there are in each of our kidneys. It's an enormous number. We measure a test in the blood called creatinine. And the creatinine is handled and excreted by the kidney, and it's a very nice test for kidney function. And by function, again, I mean the filtering ability of the kidney. Now, I never talked about how much the kidney filters. It actually filters 140 liters of fluid a day, both kidneys. You can imagine a 2-liter Coke bottle of Coke Zero. Each bottle is 2 liters. The kidney filters 70 of those a day. That's how much fluid comes through all our 2 million glomeruli. Remember, there's 1 million in each kidney. So it's a humongous amount of fluid comes through, 140 liters. But think about it, we only pee out 1 liter. So we filter through all the filters 140 liters, and only 1 comes out in the toilet every day. So we must be reabsorbing in the rest of the so-called nephron 139 liters a day, and that's actually what's happening. So we filter a huge amount, but the kidney is able to reabsorb 139 roughly, back into your blood so that only 1 liter of urine comes out every day. If you drink 2 liters of water a day, the kidney will reabsorb 138 of the 140 and pee out 2 liters. If you drink 3 liters of water, the kidney will filter 140, reabsorb 137 liters, and pee out 3. So that's how it works. Now, the filtration function we can get indirectly from measuring the creatinine. So a normal creatinine is around 1. If the creatinine goes to 2, you've lost half of your filters. So you went from 1 million in each kidney to 500,000 in each kidney. That's how it works. If the creatinine in your blood goes to 4, you've lost 75% of your filters. You have a quarter of them working now. And as I said, when you get down to about 15% of your filters, you need to go on dialysis or get a kidney transplant. So when the creatinine gets to like 6 or 7, patients usually need to go on dialysis. It's one of the indicators. So we use the creatinine I mean, I'm sure you've had your creatinine measured hundreds of times and didn't even know it. It's part of just a routine blood test, but the doctor is looking at your kidney. Now, the problem we have is that GPs and primary care physicians, when let's say the creatinine came back at 1.6 or 1.7, they'll ignore it. They're not attuned like a nephrologist is to focusing on the level of the creatinine. We get worried when it's 1.2 or 1.3. We know something's going on in the kidney, even though it seems like the change is only small. That is an alarm button for us that something is affecting the kidney. But other doctors, even subspecialists like cardiologists, they won't notice it. It'll come back 1.2, 1.3. They'll go, it's close to 1. Everything is okay. But that patient already lost, 10, 15% of their renal function. So for us, it's a red flag. Unfortunately, we don't get sent patients with abnormal creatinines unless it's like 2, 2.5, but the patient's already lost half their kidney function by then. It's way too late. But that's the life of a nephrologist. We are referred patients way too late. The other thing we look for, in addition to the creatinine in the blood, is we look for what we call protein in the urine, because as I mentioned earlier, the normal kidney prevents protein from coming out in the urine. We don't see it. But a patient who has damage to the filter not only doesn't filter enough fluid, it also lets leak through too much protein, and that protein will get into the urine, and we measure it. So we measure it with what we call a dipstick. That's that little stick on the top of the container there. It's color coded, and the more protein there is there, the different color we'll get. So we get an indirect assessment of how much protein there is in the urine, and then we'll send the urine off to the lab to get an actual measurement of the amount of protein. The dipstick just gives us a rough idea there's something going on, but we can actually quantitate and get a number back for how much protein there is in the urine. And we actually follow that number when we treat people, because that's one of the things we do in the clinic is we try to diminish the leakage of protein into the urine. There's some evidence that damages the kidney, and also their kidney function, their filtering ability lasts longer and doesn't decline as quickly if we can prevent the kidney from excreting as much protein. Now, this is a question we ask medical students, because when there's protein in the urine, there's always bubbles there because it affects the surface tension in the urine. We ask the medical student, what's the most common cause of bubbles in the urine? And, a lot, not just students, residents also, they'll say, oh, protein in the urine. We'll go, no, it's from peeing too high. You just made bubbles. So they laugh, but it's true. Having protein in the urine is one of the causes of bubbles in the urine, but it's certainly not the most common. Now, the other thing we look for is blood in the urine, and the amount of blood will determine how red the urine is. And as I say, the most common cause of having red urine is having eaten beets hours before. The dye from the beet gets into the urine, the kidney filters it, and it gets into the urine. Now, the urine on the right looks normal, and you might say there's no blood in it. Well, there's no what we call gross blood in it, but there still may be blood in it. So we have to look under the microscope, and under the microscope, we look for red blood cells. And the normal urine has up to like 2 red blood cells per what we call high power field. So using a high power objective on the microscope, we should only see 1 or 2 red blood cells. If we see more than that, then there is blood in the urine, but we call that microscopic blood, or microscopic hematuria is the technical term. And that's still as significant. So we decide whether there's so-called macroscopic hematuria, which means our eyes can see it, or microscopic hematuria that we've seen only under the microscope in what urine that looks clear. The other thing we look for in urine are cells. We should not be seeing all these cells in the urine. There's something going on here. And one type of cell that we see, particularly in sexually active young women, are white cells, white blood cells, because they have a urinary tract infection. Very common in young women who are sexually active. If we suspect a urinary tract infection, we will look under the microscope and not only look for white blood cells, which is the body's reaction to the bacteria. We'll actually look for the bacteria also, which you can see under the microscope, and that's what's shown on the right there. Those are little bacteria swimming in the urine. You should never see that. The urine is sterile. You should never see bacteria in the urine, and if you do, you have to suspect a urinary tract infection. To figure out what type of bacteria, we will take the urine and put it on a plate. It's called an agar plate, and it has food in it, and the bacteria grow on it and form little colonies. So that's what you're seeing here on the left. That plate should just look pink. There should be nothing on it growing. And if stuff starts to grow, that's because there was bacteria in the urine. The lab will then put little circles of different types of antibiotic around those colonies to see which antibiotic kills the bacteria. So if the bacteria is sensitive to a specific antibiotic, you can determine that on the plate, and then the doctor will recommend that. Now the problem is this takes days. You have to wait for the bacteria to grow, and then you have to wait to see if the antibiotic little circles that they put here on the plate will kill the bacteria, and that's too late. The patient's already come to you 4 days ago with symptoms. So the doctor will guess what antibiotic to use, and then when they get the result back 3-4 days later, they'll switch the antibiotic to the right one. Now oftentimes they guess it correctly and they don't have to switch, but sometimes it turns out that the antibiotic you put the patient on, this test showed the bacteria is not sensitive, and so you're just wasting your time. You need to switch to an antibiotic that will work. The symptoms of this are usually burning when you pee, or you have to pee a lot. This is something that's not discussed in the elderly. People who are in their late 70s and 80s, the tissue in the urethra and the bladder doesn't fight off bacteria as well. So it has nothing to do with being sexually active. It has to do with the fact that normally our urinary tract has certain chemicals that kill bacteria, and so we don't get infected all the time. But when you reach those elderly ages, you're able to less efficiently fight off the bacteria, and it's very common in someone in their 80s in a nursing home to just get recurrent urinary tract infections. And in the elderly, it doesn't present with burning. They don't come in and say my urine burns. It presents in a very funny way. They typically have altered mental status. So the daughter will say, you know, her father was in the nursing home and the father's just acting weird. The first thing you have to think of is a urinary tract infection. It's the most common reason for changes in mental status in the elderly. I'm not talking about chronic changes like Alzheimer's. I'm saying the person was functioning pretty normally, and then the next day they just started acting weird, sleeping or talking weird, or just something changed mentally. The first thing you have to think of is they have a urinary tract infection, and you have to take the urine and screen for bacteria or whatever. And it's often missed. Doctors don't think of it. No one thinks about it. But once you start getting into that kind of thought mode, it's something that you can do often, and you can help a lot of people that way. Now, one thing we do, because these people can get an infection every 2, 3, 4 months. I mean, they're constantly being put on antibiotics, taken off the antibiotic. is to put them on what's called prophylactic antibiotics, where they're on the antibiotic all the time, low dose. Now, the trouble with if you put someone on an antibiotic all the time and it's a full dose, what happens is you get what's called a superinfection, either from bacteria that are resistant to that antibiotic, or you can actually get yeast and fungus growing. The yeast, for instance, Candida, you might have heard of Candida, the yeast. It loves it when there's no bacteria there, because the bacteria tend to create an environment that the yeast doesn't grow in. But if you get rid of the bacteria with your antibiotic, oftentimes they get a Candida superinfection, which is really hard to treat. So we're very careful about just treating people willy-nilly full dose antibiotics for more than 7 days or 2 weeks. After that length, after 2 weeks or 3 weeks, you start running the risk of getting a superinfection. So for these elderly patients, it is a risk, but we put them on such a low dose that we're not getting rid of the bacteria necessarily totally, and there's enough left to prevent yeast from growing and preventing resistant bacteria from growing also. Now, the other thing that happens in the elderly that's very strange is when we put someone on an antibiotic, you might think, oh, mentally now they're going to be fine. But what happens is the antibiotic kills all the bacteria in your gut. Your gut has thousands and thousands of different bacteria that are living there all the time. They're part of your body. They're like a part of you, even though they're not part of you in a sense. And they make certain chemicals that go into your bloodstream. Well, in the elderly, if you get rid of those bacteria, you can actually change the chemistry of the chemicals that are going into your blood, or you can get different bacteria growing, and that can make the elderly have altered mental status. So you've solved one problem with your antibiotic, getting rid of the infection, which by itself can make them act abnormally. And now you've replaced it with another problem where you've rid the gut of bacteria, and that can make them. So it's very frustrating for the children and obviously for the patient themselves. But it's just something you have to think of. And I will stop there. Here are 2 happy kidneys. I hope you keep your kidneys happy. Make sure you know what your creatinine is. And I would measure it every year or so. Make sure you follow it, and it should be near 1. If it goes above 1, 1.2, 1.3, 1.4, please let your doctor know that you've noticed it before them, and have them send you to a nephrologist for further workup. So I'd be glad to take any questions. I'm sure there might be a few. Anyone want to unmute? No, it was all clear. Okay, I think I'll stop there. Thanks for your attention. Bye-bye.